Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
So we got dentoalveolar today. And first up, Anna and Mo. Very nice.
All right, let me get my timer going here. And we will get started.
Yeah.
Okay. Ready?
Let's do it.
Yep.
Okay. All right, so you have a 14-year-old female referred by her orthodontist. She comes in with her mom. How would you proceed here?
So I'd want to find out from her how long she's been in ortho for, and I'd want to get all the records from the orthodontist and any other pediatric dental records that she might have. I'd want to know what the spacing is of the area there. I'd want to I want to find out her past medical history, medications, allergies, social surgical history, do a physical exam and get some imaging.
Okay. So, not allergic to anything, medical history largely non-contributory. She is not in ortho yet. She's about to get her braces put on shortly. The orthodontist wanted you to take a look at her first. These are her vital signs. Do you have any questions or concerns about any of this information?
Yeah, her heart rate's 50 on a 14-year-old, so I would be kind of concerned about that just from baseline. So I'd want to talk with her mom to find out if she's been to the pediatrician in the past and what they've said about her heart rate.
Okay. Anything else?
Not based on that. Oh, BMI 14.6, so she's severely underweight.
Yeah. Any questions you would have about that?
Yeah, I'd want to know what her eating habits are. If she has any like poor habits, like does she avoid eating? Does she vomit? What her overall body habitus looks like. Clearly, this would be an anesthesia concern.
Yeah, so she's really cagey about that. Doesn't really give you too much information. Could you tell me a little bit, or could you define for me anorexia nervosa versus bulimia and what you might see in those patients?
Yeah, so anorexia is lack of nutritional intake versus bulimia, which would be nutritional intake, but then forced vomiting after. The main thing that you'd see with bulimia on an intraoral exam would be acid erosion of the teeth due to the vomiting.
I understand. So you don't see any acid erosion. You don't see any callousing on her fingers, anything like that. But you do have some concern that she may be anorexic or have a restrictive eating pattern. Any other signs or symptoms you would see on exam for an anorexic patient?
Yeah, she would just be overall pretty cathartic. She would be possibly a little bit more pale, and she can have some ocular disturbances as well.
And how would this impact your preoperative workup if you're planning on taking her to surgery and sedating her?
Well, I'd need to know her nutritional status. I'd want to know her electrolyte levels, and she would need to be properly hydrated and make sure that I can get her electrolytes back to a normal range before sedating her so that she can properly respond.
Okay. And would this impact your sedation, other than the workup you just mentioned with respect to electrolyte abnormalities and nutritional status? Would this affect your sedation plan at all? And how so?
Yeah, I might not want to do it in the office. I might want to do it in the hospital, speaking with an anesthesiologist who can monitor her a little bit more closely.
Okay. All right. So could you describe this image for me?
Yeah, so this is a non-diagnostic panoramic X-ray. She has a full complement of dentition with an impacted tooth number 6 that appears to be at the level of the crest, but crossing the lateral incisor over 100%, even encroaching onto the area of the central incisor. She's got 4 full bony impacted canines. I
understand. So are you going to offer her removal of her third molars? Are you just going to discuss the canine? What would your plan be for her?
I personally wouldn't offer her anything yet. I would have this conversation with her orthodontist who referred her over to me, and I would have that discussion with them based off the timing. These third molars are pretty close to the crest. So if the orthodontist recommended a removal, then I would agree with it because it wouldn't require too much bone removal to access the third molars.
Okay, fair enough. The orthodontist says, yeah, he wants you to go ahead and take out the third molars. What is the order of impaction frequency by tooth? Like, what is the most commonly impacted tooth? And from there, what is the frequency of?
So most common impacted tooth are the third molars. Then you have your canines, then or maxillary canines, then you have your mandibular premolars.
Okay. What are some theories of tooth impaction? Why are these teeth impacted? Or why are teeth impacted in general?
It could be a canine or the lateral incisor, like the guidance eruption theory, where lateral or missing lateral incisor.
Okay. What about the third molars?
Third molars could be due to the arch space in the area, or it could be due to thickened buccal cortexes as the teeth can be displaced towards the buccal aspect.
Okay. What's the Pell and Gregory classification of 17 and 32? And can you describe that classification to me, please?
Yeah, so Pell and Gregory classification is broken up into two different categories. One would be based off of the level of the occlusal plane, and the other one would be based off of the ramus. So the occlusal plane would be based off of A, B, and C. A would be at the level of the occlusal plane. B would be, within 50% of the occlusal plane, and C would be below that. And then for 1, 2, and 3, it's completely behind the ramus at a 1. 2 would be about 50% through the ramus, and 3 would be completely.
Okay. So what are these teeth?
So these teeth would be a Pell and Gregory 2C.
Okay. And can you define or describe the Winters classification for me?
So the Winters classification is based off of the degree or type of impaction that it is, whether it's a mesioangular, horizontal, buccolingual, distoangular, and just kind of the rotation of the tooth itself.
And what are the indications, or what are some indications for the removal of third molars?
Orthodontic treatment, pathology, pain, contact sports, having a higher risk of fracture, pericoronitis, infection, caries.
What is the ideal time to remove a third molar?
Around 16 would be ideal, and preferably before the age of 25.
And what are you basing that on?
Vertical ramus height and changes of the bone and mandibular growth, and where the tooth is in position compared to the crest itself in terms of the earlier age, and then the later age is based off of the complication rates as patients get older.
Okay. Moving back to the canine. So your CBCT is broken. How would you radiographically locate this canine? How would you figure out where it is in space?
So I can do the slob technique with periapical films.
Can you describe that for me, please?
Yeah, so the slob technique stands for same lingual opposite buccal. So I would take at least 2 periapical films, the first being directly centered over the tooth, and then I would move the cone head either to the right or to the left. And if the tooth moves in relation to the root in the same direction as the direction that I move the cone head, then it's lingual. And if it moves the opposite side, then it's buccal.
Got it. I understand. All right. So you decide to remove the third molars and do an expose and bond on the canine. When you're extracting tooth number 1, you know that it's been displaced into the maxillary sinus and you have a pretty large perforation there. How are you going to manage this?
So the first thing I would do is I would try to visualize the tooth and see if I can retrieve it with my suction. If that doesn't work, I can try sticking some iodoform gauze up there and seeing if when I pull the iodoform gauze out, I can pull the tooth out with it. Another thing I can do is a sinus lavage and see if I can get the tooth to mobilize that way and then irrigate it out. If all those techniques fail, I can do a Caldwell-Luck approach and directly visualize and retrieve it. Would want to get some imaging as well right after it displays to be able to identify and localize it.
With your Caldwell-Luck approach, are you going to do that immediately or are you going to wait?
I would do that immediately.
Okay. So you perform the clawball luck, you remove the tooth. How are you going to close this oral communication?
The oral intercommunication in the area there being 12 millimeters, I would consider doing a buccal fat flap, but this
How
patient
many lobes does the buccal fat pad have?
got 4 lobes.
Okay. What are they?
I don't know.
Okay. Can you describe your technique for me?
For
Actually,
the
don't describe your technique for me. What are your sinus precautions for this patient?
Sinus precautions would be no nose blowing, sleep with your mouth open, sleep with a couple of extra pillows to sleep a little bit more elevated. I would prescribe them augmentin, sinus decongestants, saline nasal
What
spray.
is augment? How does that work?
Augmentin is a penicillin family drug. It's amoxicillin and clavulanic acid. It's a beta lactamase, and you give the clavulanic acid to be a beta lactamase inhibitor for the
Okay.
sinus.
All right. So you took care of that, but now 16's in the infratemporal space. What are the boundaries of the infratemporal space?
The infratemporal space is bound by the lateral maxillary sinus wall and pterygoid junction on the medial aspect, and on the lateral aspect, the zygomatic arch.
Okay. How does this typically happen if you're displacing a third molar into the infratemporal space? What has occurred most likely?
Most likely, it's due to poor vector force
Okay.
or lack of protection with the retractor.
And what is the most common position in the infratemporal space? Where would you expect this to go?
Where would I expect to go in the infratemporal space?
What's the most common position? Okay. How are you going to manage this?
So I would try to identify it clinically. If I can extend my release and flap it up and see if I can identify it and retrieve it with a hemostat. If I can't retrieve it with a hemostat, I would allow the tooth to fibrose for 4 to 6 weeks in the area and then consider retrieval at that time. But I would talk to the patient. I would let them know that during this time of allowing it to fibrose, we would assess them for any functional difficulties or limitations, and we can even consider leaving it to minimize additional future surgeries. If they do have any issues or we do need to go in there and take it out, what we can do is we can localize it with a needle and dissect along the needle to get.
Okay. Awesome. That was time. Good job.
Awesome. Thank you. What are the what's the most common location? That's an
To be fair, I pulled that out of the blue book. Lateral and inferior to the pterygoid plate.
okay.
I didn't know that either.
That's a good one.
4 lobes of the buccal fat pad. That was the kicker for me.
I had to throw some oddball questions in there.
I think it's like there's like a pterygoid lobe, right? Like a buccal lobe.
So I thought there were 3 lobes, but I think it's been debated that there are 3 versus 4. Article here. So your posterior lobe is subdivided, but the buccal fat pad, 3 separate lobes, anterior, intermediate, and posterior. And then the posterior is subdivided into the temporal pterygoid, pterygopalatine, and buccal extensions. Totally not something you need to know, probably, but anyways, good job.
It's funny because I think it was my chief back in residency. He practices up in Canada now, but on his board exam, I guess in Canada, they asked him to draw the buccal fat pad, which is
just like a big blob.
It's an even weirder thing. I'm not sure I'd be able to draw it accurately, but it may come up.
Okay, so overall, I thought you did really well. I didn't really stump you on anything except for those weird questions. With respect to the bradycardia, that is associated with eating disorders. So that's why I threw that in there. I might have overshot it a little bit and accidentally sent you down the wrong path. But in terms of your workup, you got the electrolyte abnormalities, dehydration you hit as well. Amenorrhea would be one. Delayed gastric emptying may have some bearing on your anesthetic plan. Let's see, what else? Oh, potential that they could have prolonged sedation from slow metabolizing of drugs. Maybe consider getting an EKG. Potentially consider LFTs as well. But I thought you did really well on that.
Yeah, thanks for throwing some medicine in there. That's good.
You're welcome. Let's see. You got order of impaction, you nailed. Theories of impaction, you got most of those. Pell and Gregory, I think you were good there. What I was looking for with I agree your age range is appropriate, but I was also looking for root formation potentially, like 2/3 root formation as being the ideal time.
That's what you meant by timing. Oh, gotcha.
Which would have fallen in that age range, but I thought your answer was appropriate. Your indications were right. Slob rule you got.
Hey yo. I gotta sharpen my swords for the oral boards. I learned them from Patel and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go ooh ah like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.